Thanks a lot, Will, for that nice introduction, and thanks for the opportunity to give this talk. With some background, I will describe the isolated, ventilated, and perfused lung of the rat as one versatile model in preclinical drug development. Integrated into the precise inhale exposure platform, different aerosol formulations can be evaluated for lung PK and ventilation mechanics with a minimum of translational errors. 4 different formulations of the antibiotic apomycin were evaluated and compared for lung PK and mechanics in the IPL system. I will illustrate the use of the IPL by presenting data from the European multi-center project APRINIA, which is new inhalation formulations for improved delivery of antimicrobials. This is a 3-year project with a €1.5 million budget to identify, characterize, and optimize a nanoparticle formulation technology best suited for respiratory delivery of apomycin and other antimicrobials. And 7 different partners, if you can see this, were involved in this consortium, and directly involved in the IPL study were these 4 partners, which is Aciditech in Spain, Insem Poitiers in France, Inhalation, and Rice from Sweden. Apomycin is an aminoglycoside antibiotic with a high solubility in water and actually belonging to the IBCS class 3. And it is a repurposed veterinary drug substance, and the unique structure of apomycin make it less susceptible to common aminoglycoside resistance mechanisms. And 4 different formulations of the APRA were used in the study, or rather 1 nebulized reference and 3 different engineered formulations. The formulation 1 was the reference, the baseline, a solution of 7.5 milligram per milliliter of APRA just in water, delivered by Rice. Formulation 2 was the CUDA APRA, which is a nebulized dextran-based nanoparticle suspension from Aciditech. Formulation 3 was the DSPC APRA, a dry powder consisting of micronized apomycin coated with a surfactant DSPC, was delivered by Rice. And formulation 4 was the gallium apomycin, which is a dry powder consisting of a nanoparticle formulation of apomycin complexed with gallium from Insem in Poitiers. The study was performed using the precise inhale exposure platform. It can be basically viewed as an inhalation switchboard with the dispensing system, precise inhale, in the middle, receiving aerosols from 3 alternative aerosol sources, either compressed air dry powder generation or a mechanism for actuating clinical inhalers such as PMDI or DPIs, or a mesh nebulizer for wet aerosols. The aerosols extracted into this dispensing system can then be delivered to several alternative exposure modules, in vitro, ex vivo, and in vivo. I'll just mention here the non-biological in vitro system Dissolvit, which is simulating the dissolution and absorption of powder drugs in the lungs, on which we actually have a poster at this meeting by my colleague Maria Malmlöf. And then the Exposal-E, which is the ex vivo, or rather, excuse me, the isolated perfused lung, which is really the subject of this talk. I skip over the rest, but this is basically in the current project, we will combine the dry powder generator and the nebulized aerosols with the IPL module. And just a quick look at the isolated perfused lung model. This is a negative pressure ventilated rat lung suspended in its glass thorax chamber. And aerosol exposures are done via a tracheal catheter. It is supplied with a single pass perfusion line. In the current exposure series, perfusion was maintained for 2 hours, and after which it was collected in a fraction collector. During this period, also the lung mechanics were monitored and recorded. And after the perfuset collection period, an overall mass balance was established to get an accurate dosing characterization. Now let's just have a look at the consistency of the exposures with the 4 formulations. The particle sizes, as you can see, stayed within a range of 2.8 to 3.6 micrometer, giving around 50% deposition in the lungs of the inhaled amount, with about an equal fraction depositing in the alveolar and in the bronchi. The exposures were also quite even, with doses ranging from 120 to 150 micrograms per dose occasion, corresponding to a similar human exposure level, scaling it up somewhere in the neighborhood of 10 milligrams of apramycin per exposures. And these are the PK data for the 4 formulations, and they came out quite differently, as you can see. On the left here, we have the dose-normalized perfusate concentrations, where reference apramycin is the gray curve in the middle. 2 of the engineered formulations, the CUDA and the DSPC apramycin, had the expected slower lung absorption compared to reference. The CUDA APRA, the red one, actually stayed below the reference throughout the 2-hour measuring period. However, quite unexpectedly, was the increased lung absorption rate observed for the gallium apramycin, the blue curve, and the right panel shows actually the corresponding fractional retention based on the mass balance for the 4 formulations. But please note the substantial difference in average variability of all perfusate measurements between the different formulations, with a markedly lower variability of the slower CUDA formulation. This is most likely caused by differing mechanisms for rate control between the formulations, where the slower CUDA seem to have a much tighter regulated mechanism for release than the other formulations. And these are the key PK results, basically. So compared to reference APRA, the CUDA and the SPC had an expected slower permeation in the lungs, with half-lives ranging from 4.5 to 6 hours compared to 4.1 hour for the reference. In contrast, the gallium apramycin permeated the rat lung markedly faster, with a half-time of only 1.9 hours, actually. The table also shows to the right here the distribution of APRA between the major compartments of the lung, while the data showing fractional distribution of APRA between lung tissue, extracellular lining fluid, and perfusate, they look fairly similar in fraction numbers. But it is clear that when the small volume of the extracellular lining layer coating the airways, of course, means that the apramycin concentration was several orders of magnitude higher than for lung tissue and perfusates, which actually should, I guess, be an advantage for a respiratory infection antibiotic. Now, what is the likely behavior of an IBCS class 3 compound in the air-blood barrier? The pulmonary absorption process of a particle-associated solute can basically be divided into dissolution and desorption from the carrier particle, permeation of the air-blood barrier in the middle, and the perfusion out into the circulation in the 3rd step. And a class 3 substance with a high solubility and a low permeability should have its overall permeation rate controlled basically within the epithelial barrier itself in step 2, gray here in the figure. engineering the particle release rate should therefore only be able to decrease the overall permeation rate, such as observed for the CUDA and the DSPC apramycin. Now, that an increase is actually seen in the gallium apramycin permeation, this actually would suggest that an increased permeability of the barrier has occurred. And then, of course, you want to know, do we have any evidence for that happening? And if we then take a quick look at the effect of these 4 apramycin formulation exposures on lung mechanics and perfusion rates, here we have the 2 parameters. On the left, the tidal volume over time, and to the right, the perfusion rates. And it is clear that reference CUDA and DSPC apramycin exposures had no noticeable effect on lung physiology at all. In contrast, the gallium apramycin exposures caused a transient but rather dramatic decrease in the tidal volumes and a marked dip in the perfusion rates lasting for about 30 to 45 minutes, which are shown here with the blue curves. And these effects vanished after some 45 minutes, and actually no observable effect on lung physiology was seen at the end of the experiment, so they are completely normal. So with that, it is actually time to conclude. For the IBCS class 3 drug, apramycin, high solubility, low permeability, it is possible to alter lung PK by using various engineered formulations. And 2 of the formulations, CUDA and DSPC APRA, did slow overall lung permeation compared to the reference. And 1 formulation, the GALA apramycin, increased lung permeation compared to the reference, most likely affecting the barrier function of the lung itself. And the low variability of precision dosing with the precise inhaled system allow a minimum numbers to be used, in this case N3, still providing a mechanistic understanding of the lung PK. I suppose thereby we're bagging 2 of the 3 R's, namely reduce and refine. And with that, I'm just like to thank for your attention, and a general thank to all the groups involved in this project, and a particular thanks to our in vivo expert, Eva Selj at Inhalation, who made this delicate data harvest possible at all. So, and with that, I'd be happy to answer any questions. Thank you.
Okay, thanks very much. So does anyone have any questions on the floor? Just to remind you, we've got some microphones at the back and the front, or you can raise your hand and someone will come over. Perhaps while we're waiting, I'll ask a quick question about the translatability of the IPL to humans. So you observed this quite interesting increase in permeability for one of your formulations, but the precise inhale reduces variability dramatically. So how would we expect to see that in a human PK study, for example?
Yeah, that's a good question. I mean, it's because any biological variability is probably a lot larger if you have a human group rather than is fairly more genetically like rats. So I suppose that may be a problem. But one advantage of decreasing the dosing variability is actually that then you know that the variability you do find in your experience is really a biological response that is of interest, rather than sort of a poor dosing procedure, which is not so good. But yeah, but it is to unknown to of course, how much you can extrapolate between the 2 models.
Interesting, thanks. Okay, so any questions from the floor? If not, then we can move on. So yeah, we'll thank Per again.
Great, thanks. Yeah. Bye.